Hi, welcome to Pearls, Procedural Education for Adaptation to Resource-Limited Settings, part of the Sugar curriculum. These modules are available online or on your phone and intended to help you prepare for work in resource-limited settings. We're all quite comfortable when we have the medical supplies we're used to, but take those away in resource-limited settings and things can get challenging. That's what this series is about. In this session, we'll learn the basics for initial treatment and care for burns in resource-limited settings. The session will be led by Dr. Andrew Karagu and Jessica Pearson, who will go over the basics of burn care. Before we get started, a quick reminder. These sessions are not intended to teach detailed specifics of the medical management of conditions discussed, but rather to equip you with the ability to solve problems when you don't have the resources you're used to. Be sure to check out other resources online and in textbooks for more specific information. Now let's hand it over to Dr. Andrew Karagu, who will go over the basics of initial burn care.
Globally, nearly 100,000 children die each year because of burn injuries. Unfortunately, the great burden of these injuries and deaths are borne by children in low and middle income countries. There are significant challenges faced when dealing with burns in these countries, and these include inadequate infrastructure, lack of specialized staff, including burn surgeons, anesthesiologists, nurses, and other care providers, as well as lack of access to supplies such as clean water, topical antimicrobial agents, specialized dressings, IV fluids, and airway equipment, to name a few. Unfortunately, many children also present for care late, and some of these children may have received local traditional treatments that may cause additional harm. Burn injuries are classified by the depth of burn and the extent of the body surface area that is involved. This first photograph illustrates a child with a first-degree burn. This burn involves a superficial layer of the skin, the epidermis, and the most common example of this type of burn is sunburn. The burn can also result from a brief exposure to a flame. The skin may appear red, and the surface of the skin is typically dry and quite painful. However, these burns heal within 3 to 6 days with supportive care. The second photograph is that of a child with a second-degree or partial thickness burn. This involves the epidermis and a partial thickness of the second layer of the skin, the dermis. These result from limited exposures to a hot liquid, flame, or some sort of chemical. The skin may have blisters, as we see in this patient, and these burns are typically very painful but heal within 10 days to 3 weeks with adequate and proper care. The next photograph represents a child with a third-degree or full-thickness burn. This results from a more prolonged contact with flame, hot liquid, or chemical. The skin may appear waxy or white or even charred. The surface of the skin feels dry and leathery, and the burnt skin is relatively insensate. These children, in addition to the usual elements of wound care, will require skin grafting. Burn management, as is the case with the management of any other type of trauma, involves management of the airway, provision of adequate oxygenation and ventilation, provision of circulation support using IV fluids, or, if these are not available, oral rehydration solutions. Fluid resuscitation is especially important if more than 10% of the body surface area is involved. Provision of adequate pain control is also important, and while opioids work best, non-steroidal agents such as ibuprofen, paracetamol, or acetaminophen are also acceptable. Please note, in order to help you manage a burn patient, you should download or bring along with you a Lund Browder chart or similar resource to help you estimate the percent body surface area burned and to calculate the amount of fluid that you'll need for resuscitation. One of the most commonly used formulas for IV fluid resuscitation is the Parkland formula. The fluid that is typically used is lactated ringers, although if this is not available, normal saline can be used. Please note, however, the increased risk for hyperchloremic metabolic acidosis with significant amounts of saline. The volume given is typically 2 to 4 milliliters per kilogram per percent body surface area burned. Half of this amount is given over the first 8 hours and the second half over the following 16 hours. This is in addition to maintenance IV fluids. The calculation for a 10 kilogram child with a 30% body surface area burn is provided. Notice that you calculate the amount of fluid for resuscitation and then you add this to the maintenance IV fluid rate. If you are not able to give IV fluids, oral rehydrating solutions are acceptable and typically given via nasogastric tube. The volume given is 4 milliliters per kilogram per percent surface area burned, and half of this is given over the first 8 hours and the remainder over the following 16 hours. This is in addition to the patient's maintenance fluid requirement. After you have provided adequate analgesia, the next important step is wound care. The supplies you will need include clean water, bleach, gauze, Vaseline, a topical antimicrobial agent like Silvadene, a roll-on bandage like Curlix, or a cloth bandage, which you will use to wrap the burn. To make your cleaning solution, you will use the cleanest water that you have available and mix it with bleach to make a Dakin's solution. This is typically made by mixing 10 parts water with 1 part bleach. You will then use this to clean the wound and then dress it using non-adherent gauze to which you have applied the antimicrobial ointment or cream. If you do not have non-adherent gauze, then you can make your own using the gauze that you have available and Vaseline. In addition, if you do not have access to an antimicrobial agent, you can use honey instead. Make sure that you cover the burn completely and use only as much gauze as you need so as to minimize waste. You will then wrap this gauze with your bandage. This dressing will need to be changed daily. If your patient has burns that require surgical intervention, then you should arrange for transfer to the closest referral facility where this can be provided. Don't forget a tetanus booster for your patient if needed. Thank you.